Bismillahirrahmanirrahim. Quote of the day. Mental health is not a destination, but a process. It's about how you drive, not where you are going. Critical appraisal. I am Dr. Hussain Mahmood, PGR of Community Medicine. Today I am presenting critical appraisal under kind supervision of Professor Dr. Sarah Afzal. Article title: Effect of water quality, sanitation, hand washing, and nutritional intervention on diarrhea and child growth in rural Kenya. A cluster randomized control trial using consort checklist. This is checklist of we're using for critical appraisal of the article. Title and abstract. In title and abstract, we identify randomized trial in title.
Excuse me, Dr. Hussain, आपकी स्क्रीन खड़ी हुई है और आपकी स्लाइड्स आगे जा रही हैं.
Title and abstract. In title and abstract, we identify as randomized trial in title, structure, summary, trial design, method, result, and conclusion. Title: Effect of water quality, sanitation, hand washing, and nutritional intervention on diarrhea and child growth in rural Kenya, a cluster randomized control trial. It's identified as a randomized trial. Summary: we aim to assess whether sanitation water sanitation, hand washing, and nutrition intervention reduce diarrhea or growth faltering. Method: the WASH benefit cluster randomized trial enroll pregnant women from villages in rural Kenya and evaluate outcome at 1 year and 2 years of follow-up. Graphically adjacent cluster was block randomized to active control, passive control, or compound level intervention, including household visit to promote target behaviors, drinking chlorinated water, safe sanitation, consistent of disposing faces in improved latrine, hand washes with and young child feeding plus small quantity lipid-based nutrient supplement from 6 to 24 months, and combined water sanitation, hand washing, and nutrition. Primary outcome were caregiver reported diarrhea in the past 7 days and length for age Z-score at year 2 in index children born to the enrolled pregnant woman. Masking was not possible for data collection, but analysis was by intention to treat. This trial is registered with clinical trial.government number NCT 017041105. Interpretation: behavior changes messing combined with technologically simple interventions such as water treatment, household sanitation, upgrade from unimproved to improved latrine, and hand washing sanitation did not reduce childhood diarrhea to improve growth, even when adherence was at least as high achieved by other programs. Counseling and supplementation in the nutrition group and combined water sanitation, hand washing, and nutrition intervention led to small growth benefit, but there was no advantage to integrating water sanitation and hand washing with nutrition. In summary, trial design given, method given, result conclusion given, and keywords not given. In introduction, we see scientific background, explanation, rationale, specific objective, or hypothesis. An estimated 156 million children worldwide suffer from stunting and unlikely to reach their full potential as adult. Linear growth faltering is most apparent sign of chronic undernutrition and in physical manifestation of combined physical and developmental insult. Frequent diarrhea is also associated with linear growth faltering if there is a pathway independent of symptomatic diarrhea linking environment contamination to growth faltering to benefit of improving water safety. Sanitation and hand washing could be underestimated because studies have generally focused on diarrhea. It is unclear whether combined water sanitation, hand washing, and nutritional intervention reduce diarrhea or improve growth more than single intervention. We aim to investigate whether individual water sanitation, hand washing, and nutritional intervention can reduce linear growth faltering. To assess whether combined water sanitation and hand washing intervention are more effective at reducing diarrhea than individual intervention, and to investigate whether the combination of water sanitation, hand washing, and nutrition intervention reduce growth faltering more than each individual intervention. A companion trial in Bangladesh evaluated the same objective. In introduction, scientific background is given, explanation of rationale, specific objective or hypothesis is given. In method, this is checklist for method. This is checklist for randomization. The Kenya wash benefit study was clustered trial done in rural village in Bungoma, Kokenga, and Viega countries in Kenya Western region. We use a cluster random design to facilitate the logistic of the behavior change component of the intervention and minimize containment between intervention and comparison household. We hypothesize that the intervention would improve the health of the index child in each household. We optimize the trial design to measure group level difference in primary outcome by including a large number of clusters, each comprising level relatively few children, 12 centimeter average with infant measurement. Each measurement round lasted roughly 1 year and was balanced across treatment group and geography to minimize seasonal or geographical confounding when comparing outcome across group. The study protocol was approved by the Committee for the Protection of Human Subject of the University of California, Berkeley, the Institution Review Board at Stanford University, and Scientific and Ethics Review Unit at Kenya Medical Research Institute under direction of the study of investigators. Inventions for poverty action was responsible for intervention delivery and data collection. Participant villages are eligible selection into the study if they were rural. Most of the population relied on the communal water sources and had unimproved sanitation facilities, and there were no other ongoing water sanitation, hand washing, or nutrition program. Participants were identified through a complete census of sanitation, hand washing, nutrition program. Census of eligible village. Within selected village, women were eligible to participate if they reported that they were in their school or third trimester of pregnancy. Plan to continue to live at their current residence for the next 2 years and could speak Kwashi Loya English well enough to respond and interview administered survey. IPS staff formed cluster from 1 to 3 neighboring village to have 6 or more pregnant women per cluster after the enrollment survey. Randomization and masking cluster were randomly allocated to treatment using a random number generator with reducible seed at the University of California, Berkeley. Blending of participants was not possible. Participants were informed of their treatment assignment after baseline data collection and might have been the treatment assignment of nearby village. The health promoters and staff who delivered the intervention were not involved in data collection, but the data collection team could have interfered treatment status if they were intervention. They saw intervention material in study communities. Statistical analysis. Sample size calculation for 2 primary outcomes were based on minimal detectable effect of 0 to 15 in length for age z-score and relative risk of diarrhea is 0.7 or smaller. For a comparison of any intervention with the doubleized control group, assuming a type 1 error of 0.05 and power of 0.8, a non-side of non-sided test for a 2-sample comparison of mean and 10% loss of follow-up. Sample size calculation indicated 80 cluster per group, each with 10 children. In method description of trial design given, important changes to method after trial commencement given, eligibility criteria for participant given, setting and location where the data were collected given, 2 intervention for each group given, defined pre-specified primary secondary outcome measures, how sample size was determined is given. In randomization method used to generate the random allocation sequence is not given, type of randomization, detail of any restriction given, mechanism used to implement of random allocation sequence not given, who generated the random allocation sequence, who enrolled participant and who assigned participant to intervention given, relevant description of the similarity of intervention given, statistical method used to compare group for primary and secondary outcome is given, method to addition and analysis such as subgroup analysis and adjusted analysis not given. This is the checklist for result. In result, 2569 villages were assessed for eligibility and which 606 were excluded on the basis of village level characteristics. 1226 villages were grouped into 702 clusters that had 6 to more pregnant women between November 27 to 2012 and May 21, 2014. 8246 pregnant women were enrolled in the study. 281 women did not have live birth and 140 women delivered twins. After at least 3 attempts to measure each child, 6659 of 7780 surviving children were measured at year 2 with diarrhea reported of for 6490 is for children and length for age Z-score measure for 65 to 83 children. Household characteristics were similar across group of enrollment. Roughly 3/4 of participants collected drinking water from the improved sources but had a walk at least 10 minutes on average to the source. Over 80% of household owned a latrine, but less than 20% had access to improved latrine. Less than 15% household had soap available at hand washing location. The prevalence of moderate to severe household hunger was 12% or lower. This is the this is a table for the baseline characteristic by intervention group. This is a table for child group Z-score at year 2 follow-up. In result for each group, the number of participants who were randomly assigned received intended treatment and were analyzed for the primary outcome. For each group, losses and exclusion after randomization together with reason given, dates defining the periods of recruitment and follow-up given, why the trial ended was not and was stopped not given. A table showing baseline demographic clinical characteristics for each group is given. For each group, number of participants including each analysis and where the analysis was original assigned group given. For each primary and secondary outcome result for each group and estimated effect size and its precision given. Result and any other analysis performed including subgroup analysis and adjusted analysis, distinguishing pre-specified from explanatory, giving all important harm or intended effect in each group not given. This is the checklist for discussion. In the vast benefits cluster randomized trial, who found no effect on the intervention on keywords reported diarrhea prevalence during the first 2 years of life and improvement in growth were only observed in group including the nutritional intervention. We concluded that combining nutrition with water sanitation and hand washing did not provide additional growth benefit beyond nutrition alone. Although the effect of water sanitation, hand washing, and nutrition on mortality was not significant. The lower mortality in that group is consistent with the statistically significant effect of water, sanitation, hand washing, and nutrition on mortality in the Bangladesh trial. Pending analysis will evaluate potential difference in effect on other child health outcomes. Discussion. The trial limitation, imprecision, and relevant multiplicity of analysis given source of potential bias not given generalizability of the trial finding given interpretation consistent with result balancing benefit and harms and consistent other relevant evidence given. This is checklist for other information. Other information, registration number and name of trial registration given in summary. Where the full trial protocol can be assessed is not given, source of funding and other support role of funders given. Title explanatory with type, objective, and type of study abstract, including all subheading with explanation. Methodology well explained. Results show association of different parameters and elaborated in form of tabulation. Way forward is mentioned. Graphically representation of result is given. Limitation structure study is not mentioned. Keyword not given in abstract session number, and details were mentioned in keyword. Limitation of study mentioned, not mentioned, or sources of potential bias is not mentioned. This is our YouTube channel link, and thank you so much. Assalamu alaikum.